So I have the distinct pleasure of introducing Dr. Mercedes Becerra, who is an associate professor in the Department of Global Health and Social Medicine at Harvard Medical School. And I'm delighted that she's part of this program because I think it's going to continue the theme of being in the right place at the right time, being observant, caring about people, and asking a question and a problem and putting some face to it. I was pleased to be able to introduce her because I think she's going to have the pediatric component of our symposium today, and is going to talk to us about some of her epidemiologic studies and drug-resistant TB and throw in some kids along the way.
Thank you very much. Good afternoon. I want to express my thanks to the organizers for the opportunity to speak with all of you today. I've been working on MDR-TB for a long time now, but I only became focused on this question 3 years ago in March 2011 when I needed the answer and it was nowhere to be found. So on behalf of my 8 co-authors, I'm very happy to share these results that have just been published on Monday in The Lancet. However, as you'll see, the results themselves are grim. 3 years ago, I had to discuss the results of a study from Peru where my collaborators and I had gathered information going back to try to reconstruct the story of what had happened to a large group of children who'd been exposed at home to MDR-TB. And I wanted to put our observations in some global context. I learned quickly that the problem in getting a handle on this number wasn't just all the challenges that accompany drug resistance, which is what I was used to thinking about. The additional problem was childhood TB, that actually there were no good data at all about the incidence of any types of TB disease in children. I read more and began to understand why it is said that children with TB have been invisible. Colleagues at Médecins Sans Frontières, MSF, among others, have been calling for attention to this problem for a long time. Later in 2011, they published this important paper. They compared available estimates of pediatric HIV to pediatric TB. In contrast to HIV, they showed that in TB, we had no sense of total disease burden, a vague idea of numbers on treatment, and no sense of the magnitude of the treatment and prevention gaps. In fact, I learned that what we have can be described as the perfect recipe to make children with TB invisible. First, childhood TB is different from adult TB in numerous ways. One is that children are more likely to have extrapulmonary disease. Another is that children are more likely to have a lower bacillary load than adults. Another is that children progress more quickly if they're going to get sick. They progress more quickly than adults to disease and death. Second is the frame that has dominated TB policies in most of the world for at least 20 years, which has assigned priority to smear-positive cases, to the infectious cases. Forget the other ones. So it's very difficult to obtain bacteriologic confirmation of TB or drug-resistant TB in a child, and without those diagnoses, it follows impossible to estimate disease burden. So if I add my MDR column here, you see why I should not have been surprised that I couldn't find a burden estimate. But I was, and I thought we have to try to do something about this. This is simply deadly for children. So I spoke with my friend and colleague, Ted Cohen, who agreed emphatically. And over the last 3 years, we pulled together the best team we could to go after this first number, the MDR-TB burden. Along the way, we also produced what we think is a better estimate of TB incidence. Now, before I tell you the results, I'll tell you what we had to do and why. So where do you even start? We thought about how you would estimate a number of sick children in one place. To your population estimate, we want to apply an incidence estimate, a rate of cases per population, and to that number of children with TB disease, you want to apply some proportion that has MDR-TB. That should be easy, right? Well, of course not. So here's what we ultimately did. A population estimate you can find using United Nations data. Then you hit the first roadblock. As I said, there are no country-level incidence estimates of childhood TB. So what data are available by country? Remember, we need data that are reported separately by age group, for children and for adults. The one piece of data that is available for 150 or so countries and that is reported by age group is the number of reported cases of smear-positive TB in 1 year. But there's a problem with these data. They are only about patients with smear-positive TB. And we know smear microscopy does not work well for children. So we thought, how can we adjust for this smear problem? We went back to this graph from a paper from 1990, which became a very important tool for our analysis. It summarizes data that are quite difficult to have. It tells us by age group the proportion of all TB cases that are expected to be smear positive. So we see that while the age groups older than 14 years had a similar smear positive proportion of between 50 and 60%, children had a smear positive proportion of only about 10%. And more recent studies in high TB incidence countries have shown the same pattern. So we can apply these proportions to rates of notified smear positive cases to scale them up appropriately. How exactly does that work? This means that we use smear positive case data as follows. For every adult case of smear positive TB reported, we count about two true adult cases. However, for every child case of smear positive TB reported, we count about 10 true child cases. Then we add these counts in each place, and we have a new estimate of the total number of true TB cases in that place. And this new estimate accounts for how smear microscopy misses child cases at a different and quite larger rate than it misses adult cases. So we can make this adjustment for the countries that reported smear positive cases by age, and that would give us a more believable estimate of TB incidence in children and adults in those places. Great. But what do we do about all the countries who did not report smear positive cases by age group? What other options do we have? We remembered another piece of data that is available. There are estimates of total TB incidence produced for each country, but these are not separately estimated for children and adults. We might be able to use these incidence estimates of total TB if we could find a way to estimate the proportion of all TB cases in children in each place. Now, how might we do that? We were stumped for a while. Happily, the pediatrician on the project led us back to this key paper from Professor Peter Donald of South Africa, published in 2002. Here, Professor Donald posited a very important relationship between TB incidence and the proportion of the TB caseload occurring in children. He had very few data points to graph, but the logic was and is immensely reasonable. In places like the US with very low TB incidence, the proportion of the total TB caseload that is in children is very low, in the range of 5%, and that's still true today. As TB incidence increases, the proportion of the total TB caseload that is in children also increases, but the increase is not a simple or linear increase. It is probably exponential, so that in a very high TB incidence setting, the proportion of the total TB caseload that are child cases easily exceeds 30%, sometimes more than a third of all cases. Professor Donald cited the very different population pyramids in places with high and low TB incidence. Compared to low incidence settings, places with more TB have younger populations where more children at a younger age are being exposed to these higher population densities of infectious patients. This seemed to us a very important phenomenon to consider, and if we could, to apply this relationship to country-specific incidence estimates. Rather than use Professor Donald's curve based on 4 data points, we did the following. Remember, I told you that for more than 150 countries, we had already produced our better estimates of TB incidence in children and adults, which we obtained from country-level age group case notifications that we scaled up by the Murray factors. So we plotted those as you see here. Along the x-axis, the explanatory variable is, as Professor Donald had proposed, the log base 10 incidence in each location. Along the y-axis is the elusive proportion we are looking for, the proportion of the total TB caseload that are child cases in that place. We fitted a logistic regression since we are predicting a proportion here, and found that the best fit is a relationship that is indeed an exponential increase in proportion on the y-axis as incidence increases on the x-axis. This plot was consistent with Professor Donald's idea, but now we had more than 150 data points from which we could quantify this relationship between the estimate of total TB incidence in a place and the proportion of all TB cases in that place that are occurring in children. Now, we can apply this relationship, which we quantified using the scaled-up age group data for reported cases that I described. For consistency, we applied that relationship to estimates for every country of total TB incidence for 2010. Not just those that reported smear-positive cases by age group, for all the countries using the incidence estimates. So now we are really cooking. For each country, we have an estimate of TB incidence in children and adults, which has gone through 2 important adjustments following Murray and Donald. Next, All we had to do was come up with a proportion of child TB cases that had MDR-TB in each place. In 2010, WHO had produced estimates for every country for the proportion of MDR-TB among adults with TB who had never been treated for TB. Happily, before we knew exactly how we'd finish this whole analysis, we'd embarked on a massive systematic review looking for reports of children with TB disease who had MDR-TB. We reviewed over 3,000 abstracts, assessed nearly 1,000 full reports, and extracted data from 97 studies from 58 countries. Of those, we could use less than a third for this analysis because we needed to be able to extract both proportions in the same report, MDR-TB in child cases and MDR-TB in adult cases. So this was a no stone left unturned approach. The reports that we found, that we reviewed, spanned 40 years. They were published in 19 languages, and we corresponded with 60 of these authors to see if they would share any unpublished data where we could see these proportions in children and in adults, and many of these authors did. Then what we did with these 31 studies is that we used them as data points to construct a linear regression model. For each point representing one report, on the x-axis you see the proportion of MDR-TB among adults with TB who had never been treated for TB, and on the y-axis you see the proportion of MDR-TB among children with TB. The parameter estimate for the slope is about 1, meaning the risk in these two groups is almost identical. This is consistent with the assertion that the risk of MDR-TB in both groups, in children and in never treated adults, reflects the local risk of transmitted MDR-TB, or of being infected with an MDR strain. For this part then, for each country, we used the estimates of MDR-TB risk in new adult cases and applied our parameter estimate to each country to get the risk in child cases. This means that even if there were no data at all about MDR-TB in children in a place, we could estimate it using the proportion of MDR-TB in child cases, in adult cases, and applying the parameter from our regression, from the systematic review. To recap then, for each country, we start with the population in 2010, we take smear positive case rates, notification rates, and adjust them to account for the smear blindness problem. That gives us improved TB incidence estimates for adults and children. We use those data to refine the idea posited by Professor Donald, which allows us to predict for all countries the proportion of the total caseload that is occurring in children. All that gives us the number of children with TB in that place. To that number, we apply a proportion, MDR-TB, which combines risk estimated for new adult cases there with our parameter from the systematic review. We did this for each country and summed these totals for the countries in each of the political regions defined by WHO. So here are the results. We estimate that about 1 million children become sick with TB every year, and now we have the number of MDR-TB cases I told you I wanted 3 years ago. We estimate it is about 32,000 children every year. The estimate of total TB cases is double that was recently estimated by WHO for the first time 18 months ago. About 400,000 children develop TB, we think, in the Southeast Asia WHO region, nearly 300,000 children in the African region, and nearly 200,000 children in the Western Pacific region. Of the total 32,000 child cases of MDR-TB, a third or 10,000 of them are in the Southeast Asia region, more than 8,000 children with MDR-TB in the Western Pacific region, and more than 5,000 children with MDR-TB in the African region every year. In conclusion, now we have an initial estimate of MDR-TB cases in children every year, but to get there, we also produce what we think is a better estimate of all TB cases in children. The numbers are grim, but we think this is a step forward because we have accounted for 3 important things. We accounted for the difference in smear positive rates in children with TB compared to adults with TB. We considered the likely exponential relationship between TB incidence and the proportion of the total TB caseload that is in children. And we applied the idea that there is a similar risk of MDR-TB in children with TB and in adults with TB who've never received TB treatment. But it's really just one step forward. Of course, there are a number of limitations in this approach, which are detailed in the paper. For example, next we should work on regional estimates considering the burden of comorbidities. We can expect that that will have an important effect. But we will only have more robust estimates when we are gathering more and better information about children with TB because we are finding and treating them everywhere they are. Thank you for your attention. I look forward to more conversations.
So, Dr. Chasen.
I think this is really important and really useful, and it's reminiscent of what happened 3 or 4 years ago when the WHO changed the estimate for HIV-related TB in Africa and basically said it was twice as much. But what doesn't change there and apparently here is the total estimate, and that just can't be the case because the total estimates excluded everything that you then included. And so you're upping the ante for kids, which is important. That should up the entire estimate because the global estimates from WHO really don't include any of these data that you have. So what's the total TB burden now, not just kids?
I'll have to refer you to the the details of the analysis because it's not in the paper, but it seemed like it was another useful piece of information. It would be larger, so I don't have the number. But the hope is that next step will be actually collaborating with WHO to improve that estimate for children at least.
So can I ask both you and Rocio sort of a combined question? And that's that this model or these estimates come from a TB base and an MDR-TB base. When you're looking at multidisciplinary approaches and implementation of co-treatment for HIV-TB, then I think in the past we generally began with TB, treating TB, and then in Rocia's groups now it's clearly important to provide one-stop shopping for both infections and diseases. And I assume that when you model in children into this, you're going to ask the question about whether they live in an orphan society and what the prevalence in a non-biologic home is and how that factors into various aspects for implementation research so that you can actually provide co-treatment for both infections simultaneously. I think what you're finding is the tip of the iceberg again, because it has to be at least this, right? And the problem has to be amplified much farther above, and not just treatment for TB, clearly. So I wonder if Rocio or Holly or somebody who's living in the field, or Anne, of how you actually implement these findings and how you can go forward with that to assure that you're not doing the wrong thing right off the bat, and to take into that the societal impact and the sociologic impact of treating MDR-TB, which we used to think was stigmatizing enough, and add the stigmatization of HIV along with that in a co-treatment environment.
I think that's a extremely relevant point. I think we really, with kids, they're the really, really poor stepchild of the TB epidemic. And I think now the burden of detection is clearly, the stakes are even much higher than we thought. And it's, even though there have been some advances made in TB diagnostics in kids, we do also have to accept that if we want the tidy world of culture confirmation, that we're going to be only dealing with the tip of the iceberg, and that we do need to be flexible and a little bit more open in the medical sense in terms of trying to capture this. A little bit like appendicitis, if you're not taking out a few good appendices, you're missing. And in the case of children, we really are missing a lot. And TB is a family disease, it's a community disease, and to look at it as an isolated point, and children are the quintessential example of that. I mean, this happens in households, and Peru was a leader in a lot of the case in contact household studies, and I think we really do need to increase the political will and leadership to really look at what are the approaches that are going to work in kids, because we're really they have their whole life ahead of them, and it's a tragedy when the child has it. Holly and others.
Do you have any information on sex bias one way or the other in TB in children? Whether there's more in boys or in girls?
I don't. I wonder if anyone does. I don't think so. I don't think there is any evidence for sex bias.
The old data suggests that it's very similar until people sort of get out of the house, and then it's always been blamed on exposure. Boys more than girls.
Exactly.
In the U.S., if you come down with TB, all your family, your work associates, those you closely associated with are tested. What happens in Africa if a patient shows up at a hospital and you determine that they have TB? Is there then active outreach for contacts?
Thank you for that question. That's exactly, I think, the next focus. Because I think in general that's not happening. That's what needs to be happening, and that's why children are falling through the cracks. So contact tracing, I think, in most places isn't happening.
So could we get a quick answer to that from Rosia and from Holly? What do you do in your country? Holly, you can just stand up. You have a big voice. Small body, big voice.
So I work in Nigeria, and it's definitely, it's a mixed bag. There are certain sites that implement contact tracing based on WHO guidelines well, in terms of, for example, in an adult ART clinic, if a patient is diagnosed with TB, we'll actually seek out family members and do the contact tracing, but it's certainly not widespread. And so I think it's a mixed bag. A lot of times it's not happening on a regular basis that sites are going into patients' homes to identify all the children in that household.
Understand?
As part of our MDR program, we do contact tracing as an adult, and they have, especially young children, who do active case finding. But as you can imagine, in the non-MDR setting, it's even much more highly variable. And then we do know that even data from South Africa that 75% of kids may have a household contact, and that varies depending on the series. But not every child who's diagnosed with TB or even MDR has a direct household contact either. Speaking to, there are other places where transmission is occurring, and it's harder to pinpoint when you can't find them.
And is there a policy assumption that if a family member has MDR-TB, the others do too?
Well, I know Tugela Ferry tried to look at this issue, and they have some studies that looked at this issue. And interestingly, some of the index, the household, there were different drug susceptibility patterns that didn't always mimic 100% the original index case, suggesting that potentially either there was transmission that wasn't always occurring in the home, or there was stepwise acquisition of mutations, and depending on when the infection was acquired, there were some differences.
And just very quickly, Graham, do you have something to say for South Africa?
Yeah, there are guidelines on following up family members being exposed, but they're very variably implemented and largely poorly implemented. Healthcare workers blame the load of just treating patients in the clinic and not being able to bring back family members. But where they are better implemented is in children under 5s. So well-functioning clinics will follow up children exposed in the household and get them onto treatment. And then in the pilot MDR programs, for instance, the Médecins Sans Frontières programs, they're very good at following up MDR contacts in the household.
Sandy, I wanted to add to that even so, from my understanding, a lot of countries have on the books policies that contact tracing should be done, and so it's, we're hearing it's very, very variable and probably really insignificant compared to what the need is. And then the second thing to mention is that in many countries that the requirement to access second-line drugs is a bacteriological confirmation of not just TB, but MDR-TB. So in India, our colleagues there have been trying to make the case that even if you are finding these children there right there and you cannot actually get second-line drugs for them, even if it's a household contact or a child of a patient, until that policy is off the books.
I just wanted to ask, and forgive me if you mentioned this because there was a lot of information, but has this been used, for example, with verbal autopsy? So or could this be implemented with verbal autopsy when someone's died, you're trying to find out why they died at home, saying, a lot of cases of TB die at home before they even get, better treatment. So finding out if it looks like it was TB, and it seems like they had had treatment in the past, so implying MDR-TB, that looking at children in the household for illness. So part of the extension of verbal autopsy is contact tracing in the home.
From what I understand, others will, I don't think that verbal autopsy has been used with much effect for TB because of a number of the symptomatics.
Verbal autopsy for diagnosing TB in the deceased person is very low. And
I was going to just ask Meche to make a comment or two about the Sentinel project.
Sure. So at the same time that I started this project with Anne and others, colleagues in India and really a number of places, we started a network without any funding called the Sentinel Project for Pediatric Drug-Resistant TB, and we've been working on developing materials, proposing consensus definitions for research on pediatric drug-resistant TB, running some training courses, and next we will work on a proposal, multi-site protocol, as the colleagues suggested, to do contact investigation, because that's going to be how we're going to find the majority of these children. So I'm happy to talk to any of you about that, the Sentinel Project. Thank you.